Welcome to Health Professional Radio. I'm your host, Neil Howard. Thank you for joining us this evening. Glad that you could make it. Going to have a conversation with Dr. Nader Sanai, a neurosurgical oncologist, and he's joining us as the director of the nonprofit Ivy Brain Tumor Center at Barrow Neurological Institute. He's going to talk about attacking brain cancer from a completely new angle. Welcome to the program, Dr. Sanai.
Thanks very much, Neil.
You're a neurosurgical oncologist. That sounds like a lot of work, a lot of complication. What do you do? What is your background?
It's basically a subspecialty of being a neurosurgeon. And, as you know, neurosurgeons are physicians that operate on the brain and spine and nerves. And a neurosurgical oncologist is a neurosurgeon that just specializes in brain tumor patients. So half of my time is spent treating and operating on brain tumor patients, and the other half of my time is spent running the Ivy Brain Tumor Center and trying to find a cure for brain cancer.
We're talking a specific type of brain cancer, or do you deal with any type of brain tumor at all?
Right, great question. So there are many different types of brain cancer. Some of these cancers come from other cancers in the body, and those are called metastases. And then there are other cancers that originate from the brain tissue itself, and those are called primary brain tumors. And we treat and investigate all kinds, but one of the most vexing of these kinds is something called glioblastoma, which is the same tumor that Senator McCain had, Senator Kennedy before him, and many other Americans. Glioblastoma is the most common primary brain tumor. It's a tumor that comes from the brain tissue itself, and it's unfortunately incurable for the vast majority of Americans. It's considered to be the deadliest cancer known to man.
Wow. So you say no cure, there's not even a surgical procedure that can remove tumors?
Well, when patients are diagnosed with it, oftentimes they'll go through several different lines of therapy. The first one, as you mentioned, is an operation where we try to remove, and this is performed by neurosurgeons like myself, we try to remove as much of the tumor as safely as possible. We know that that's not enough to cure the tumor, and so typically those patients will follow that operation with a combination of a certain type of chemotherapy and radiation therapy at the same time. And for many patients, this will slow the tumor down and give them a window of opportunity to keep living their lives. However, for the vast majority of patients, 95% plus, that tumor will come back. With other cancers, like colon cancer, for example, if you detect it early and remove it, it can be cured, or you can at least get a jump on treating it and get it under control. The problem with brain cancers like glioblastoma is that they're so aggressive that even if you detect it as early as possible, it still will continue to progress, to grow, and to spread through the brain and ultimately be life-threatening. So early detection, unfortunately, hasn't had much effect. In fact, it's had no effect on patients with glioblastoma. The average survival today for a patient with glioblastoma, and this is a very general number that doesn't apply individually to patients, but populationally, the average survival is around 16 months. So the window of time to get ahead of this, to treat it, and get it under control is very, very short, unfortunately, for these patients.
What about determining if a patient is predisposed? Genetic testing, is there anything that can be done if you find out that a person is genetically predisposed for GBM to maybe prevent it? Is there anything like that?
Yeah, it's a great question. So far, we haven't found many genetic predispositions to the tumor itself. There are very rare genetic disorders where patients are susceptible to developing these, but the vast majority of patients that develop brain cancers like glioblastoma are patients that develop it what we call spontaneously, meaning it's a random occurrence in their brain. It's not caused by their familial genetics. It's not caused by environmental factors per se, but rather just a spontaneous mutation. And for this reason, it's very difficult to predict who's going to get it. Glioblastoma is a disease that occurs across all ethnic and racial boundaries, across all different socioeconomic strata. And so it really is unselective in terms of who it inflicts.
Now, I understand that your foundation, the Ivy Brain Tumor Foundation, has a large influence as far as neuro-oncology goes.
Well, the Ivy Brain Tumor Center is unique, I would say, for a few reasons. The first, as you alluded to, is exactly that we operate on and treat more brain tumor patients than any other center in the United States. These are rare tumors, and so it's always helpful to be treated at a center where it's something that's seen very routinely. And we operate on about 1,300 brain tumor patients every year. The Ivy Brain Tumor itself is really focused on finding new therapies for these patients because, as I mentioned, many of them come through what we call the standard of care, having had surgery followed by a combination of chemotherapy and radiation, and then their tumors come back. And then at that point, current modern medicine really has no standard option to treat the patient with any sort of second-line therapy that will work. And so the Ivy Brain Tumor Center is really focused on finding new drugs and therapies and introducing them to patients with these kinds of diseases and identifying new outcomes and finding new avenues of hope for these patients that otherwise are facing a very difficult outlook on life.
I was under the impression, erroneously, I guess, that when cancer spread to the brain, it was always from some other part of the body. Wasn't really aware of that.
That's right. That's right. Yeah, there's two ways to develop brain cancer. One of them is, as you said, developing what we call a brain metastasis, where, for example, you have lung cancer, it gets out of control, and it spreads to your brain. And those are challenges to treat as well. However, the other version of that story is for patients that are otherwise healthy, living their lives, oftentimes young, and really have no predisposition conditions, but suddenly end up with severe headache, a seizure, or stroke-like symptoms, and then ultimately discover that they have this mass in their brain that's originated from their brain tissue itself. And it's soon after that they'll meet specialists like me, and we try to take them through this very difficult journey.
Where can we go online and get some more information about GBM, about brain cancer in general, and about the Ivy Brain Tumor Center?
We have a dedicated website, Ivy Brain Tumor Center, all one word, .org. And what the website provides is obviously some information that's up to date on the state of the art for treating brain cancer, such as glioblastoma. And then importantly, it also provides information on how to access the clinical trials at the Ivy Center. And that's really what we're specializing in, are clinical trials and experimental therapeutics for patients with brain cancer, and really a novel way of performing clinical trials. The standard clinical trial experience for a patient with cancer is that you've gone through the standard therapies, the cancer is out of control, and you get matched to a drug, and you kind of take that drug on faith and really stay on that drug for oftentimes months until you get new scans to see whether or not your cancer is responding. The way we do trials is through a mechanism called the Phase 0 clinical trial, where we perform a genetic analysis on the patient's tumor, match them often to a drug cocktail or combination of new drugs, and we give them those drugs at a very small dose before a planned operation to remove their tumor. And so when we remove their tumor in surgery, we can actually ask whether or not those drugs are working for that individual patient in that tumor tissue. And really by the time they've recovered from surgery, their stitches are out, and they're seeing their surgeon like myself in clinic, which is usually within a week of surgery, we can tell them very specifically whether these new drugs are working for them and whether it would make sense for them to continue on this therapy. So it's a way for patients that really have very little roadmap to figure out what to go on next to identify what will work in their individual case.
Thank you for joining us here this evening on Health Professional Radio. Thank you for your time, and I'm hoping that we can get together in the future and talk some more about brain tumor and any advancements in treatment that come about.
Thank you, Neil. Always a pleasure.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Transcripts and audio of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe to the podcast on iTunes, listen in, and download at SoundCloud. And be sure and visit our YouTube channel at youtube.com.